Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Remer. She's a physician and a clinical documentation specialist. Her KevinMD article is titled Fixing the Broken System, Improving Clinical Documentation in Healthcare. Erica, welcome to the show.
Thank you very much, Kevin. Good to be here.
We'll get into the article in a little bit. First off, briefly share your story and journey to where you are today.
Thanks. Well, I was an emergency physician for 25 years, and my expertise was always in documentation. I was sort of the liaison between the coders and my colleagues, trying to make sure that we got paid appropriately for what we did. And I was a half-time emergency physician at one point and a full-time mom. And my boss said she had seen a position that looked like it was right up my alley. And so I became the physician advisor for a large multi-hospital system. And when I was interviewing for it, it was the first time that it had ever occurred to me that the hospital got paid too. So I knew exactly nothing about what the documentation needed to do to support the billing in the hospital on the facility side. And my boss gave me 3 months to get up to speed, and I learned it, and it's really fascinating. And I did that for 4 years, and then I went out into I'm a consultant now, and I teach doctors how to document.
Now, what is it about clinical documentation that really piqued your passion? Because I talk to a lot of physicians, and honestly, documentation is not very high on their list. So documentation is obviously a passion for you. So what is it about documentation?
Well, it's interesting. I think that there are two kinds of people, the kinds who really liked science and math and the kinds who really liked social studies and English. And I think that if you like social studies and English, you'll understand that documentation is really important for us to convey what's going on with the patient. So I believe that it's real, the government is talking about documentation as a burden. And to me, I think that it's a responsibility. It's how we convey to our colleagues what's going on with the patients, how we take care of patients. So I think it's really important. The fact that the United States happens to use it for reimbursement is really it's really just the problem.
Tell me about the evolution of documentation. You mentioned you've been practicing for 25 years now, and now you're a consultant in clinical documentation. So I'm sure that you've seen the evolution of documentation as we transition into the electronic age. So from a high level view, tell me about that evolution of documentation over the decades to where it is today.
Well, I understand that you often have like medical students and residents who actually watch your show. So in the olden days, we actually used to have to write things out.
Yeah.
And so what happens is we had a lot of problems with legibility and finding pieces and parts of the chart, because it was not so easy to, you couldn't just click on a tab and open it up. So people in those days wouldn't do copy and paste. The reason being, it would take much longer to copy over yesterday's entry into today's. So it was a matter of convenience. You didn't want to, waste your time. So in the olden days, when we had it in paper, you couldn't read it, but it actually told the story. In 2011, the government actually offered money to the hospitals to implement an electronic medical record. And everybody said, $14 million. Yes, thank you, please. And so they implemented medical records that were electronic. And it was the infancy, right? So when it first started, their focus was in trying to make sure that people hit all the points that they needed for billing. And we started losing the story. So people started just clicking on boxes, and instead of having it tell a cogent story, it was sort of more haphazard. And then they also recognized that copy and paste was a time-saving tool. In fact, when I became a physician advisor, I recognized that copy and paste was a big problem, and I came to the administration. And they said, well, why don't we just turn the function off in the electronic medical record? And I said, oh, okay. And then I went and I sat with the residents and watched how they managed their documentation. And what they would do is control A to copy everything. And then they would control X, they'd put it into a Word document, they'd play around with it, and then they put it back into the medical record. And I realized they weren't using the copy forward function in the medical record at all. So turning off that function was not going to solve the problem of copy and paste. And so one of the things that I do actually when I'm teaching doctors is I say, okay, honestly, raise your hand if you love the convenience of copy and paste. And everybody raises their hands. And then I say, okay, now raise your hand if you love reading other people's copy and paste. And, everybody kind of looks at me sheepishly and they realize that my copy and paste for my convenience is somebody else's. I can't stand reading somebody else's copy and paste. And so you need to really try to get it into a culture. You need to get the whole institution to have a culture of recognizing that documentation is important to tell the story of the patient and to be able to further their medical care.
And you talk more about copy and paste in your KevinMD article titled Fixing the Broken System, Improving Clinical Documentation in Healthcare. Now, tell us, how did your article come together?
Well, anybody who knows me, I'm actually a pretty well-known consultant in the documentation field, and I write about documentation a lot. There's so many pieces and parts. The problem is that we're never really taught how to document. We learn by legend. So our attendings will teach us, but nobody ever taught our attendings how to document. So everybody's kind of stumbling through it. I teach I'm the course director of a 2-day course for people who've got in trouble with their medical boards. And they come in and they're mandated to be there and they're not happy. And they sit through, I have corporate compliance officer and I have lawyers and multiple people and myself speak to these folks. And one after another, as they're filing out, when we do it in person as opposed to remote, they say to me, "This was the most amazing course. Why did no one ever teach us this before?" And my answer is always the same, like, I don't know. Because to me, it's obvious that you want people to be able to document, to tell the story, and to be efficient at doing it, because nobody is Dr. House, where they have a whole week to take care of one patient with 3 minions doing their bidding. Like, everybody is busy, and you want them to be efficient. I want people to be able to know that they can document well and to try to help them be efficient and effective at doing it.
Now, from all the courses that you've taught and the clinicians that you've talked to, what would you say are the biggest gaps in knowledge that these physicians come to you with? What's the biggest kind of light bulb moment that they have when you teach them?
So that's an interesting question, because what happens is not everybody has the same gap, and not everybody has the same goal in getting them to document well, right? So when I was an emergency physician, medical legal was very important to us, making sure that you use the word alleged often, because you wanted to make sure that you didn't, cross over a legal line and make assumptions about patients being, guilty. You wanted to make sure that you were covering yourself if there was a bad outcome. But then when you're in the hospital setting, their concern is making sure that you meet medical necessity, because if the patient doesn't meet medical necessity, it isn't, you haven't demonstrated that they need to be admitted in the hospital, then you have no billable service, right? And then a lot of providers, their concern is making sure that they get paid. And, I'm sure you're aware, but maybe some of the people who are watching are not aware, that in 2021, there was a change in the evaluation and management professional fee components that were necessary for the outpatient office side. And in 2023, it actually moved into the hospital. So it used to be that you had to do history, physical, and complexity of medical decision-making. And fortunately, the AMA worked with CMS and they decided that, you know what? It really is all about the medical decision-making. So now medical decision-making and or time are the key components. So what that did was helped me when people had an issue with understanding how to document for their own professional fee. It's now aligned the interests of the hospital and the physician. So everybody needs to make sure that they're documenting how sick and complex the patient is, why they're doing what they're doing, and then making sure that that other people can tell from their documentation.
I'm an internal medicine primary care physician. So in my world of outpatient primary care, what are some of the biggest improvements that we can make that would have the biggest impact?
There's several things that you can do. First of all, people misunderstand and they think that they need to list every single condition the patient has ever had. So, you'll read the first sentence and it can be a laundry list of all the medical problems the patient has ever had. And, hardly any of them are relevant. So I think that the first thing you can do is what I call setting the table, which means that you put in the ones that are relevant. So if a patient's coming in complaining of, left-sided chest pain, then the fact that they had an upper lobectomy for cancer and the fact that they had a CABG are relevant in the context of that chief complaint. So telling your HPI, having the context and then telling the story and making sure that I think people should think kind of logarithmically. So they're asking questions and they're trying to help rule out or rule in and going down a path to try to make sure that other people understand their thought process. Then the next most important thing is when you're using your electronic medical record, make sure you edit your templates. So, everybody has their normals. And if you don't edit out when you haven't done it or it's not normal, then it's not telling the story. The most important thing, of course, is your medical decision-making and explaining why you're doing what you're doing. And it doesn't have to be long, but it has to tell the story. So if you're changing somebody's medications, one of the things prescription drug medication actually puts you into the moderate risk category in the medical decision making. But you can't just say see med list or no changes. You need to actually explain, that I thought about this patient. I've asked them about what's going on with their medications. They're not having any side effects. It seems to be controlling whatever the chronic condition is. And so I'm not going to be changing the medication, or I am going to be increasing the dosage, or I'm going to be adding something. Whatever it is you're doing, you need to demonstrate that management. The piece of it, in the office, you need to make sure that you're demonstrating that you're addressing the chronic conditions and that you are managing the medications. I would say for internists, though, one of the most important things in the hospital side is people making sure that they give the discharge summary attention. So a lot of people think that the discharge summary is just busy work. But the reality is, I'm going to ask you, don't you like reading a good discharge summary and making sure that it's telling stories so that you know what's going on with your patient? Don't you like that?
Of course.
Yeah. So, I think that that's one of the pieces that's really important on the hospital side. And on the hospital side, people never realized that the interval history was always meant to be just telling what's going on with the patient now. It wasn't, I don't know if you've ever read documentation where they copy and paste the entire HPI every single day during the admission. It's not necessary. You're supposed to be telling what's going on with the patient now.
So I want to ask that question another way and talk about red flags. And I know that you've mentioned several red flags already. Copy and paste, make sure that your templates are updated. What are other common red flags that you see physicians do?
One of the things that, in the context of not editing your template, making sure that it's telling what's going on, is you can introduce internal inconsistencies. So for instance, if you're documenting that a patient has sepsis, because of course, I forgot to mention before, the next most important thing is making sure that you are drawing your conclusions, and you want to make sure that you are taking all of your findings and everything you were doing, and you're going to then give a nice specific diagnosis. If your diagnosis is, let's say, sepsis, if in your physical exam you say the patient's alert and oriented and no acute distress, it sets up an internal inconsistency. And that can be a red flag, especially for, either a lawyer or a third party payer saying, well, if the patient was look non-toxic, then why would we pay you for sepsis? So that's a red flag. We already talked about the copy and paste. I think that really one of the most important things is making sure that you're thinking about what's going on with the patient. So, the tagline for my business is putting mentation back into documentation. I think that people have a tendency, the reason they're doing the copy and paste is just they think that it's saving them time. But the question, if 3 days in a row you're documenting hypokalemia will supplement, what you really need to be doing is not just throwing potassium at the patient. You need to be thinking, why does this patient keep getting hypokalemic? And then you need to address that. So I think that, those are some of the most common red flags that I see people doing. I see them often, another red flag would be making a diagnosis that's not present, that's not supported by the documentation. So, on the inpatient side, the clinical documentation integrity specialist, that's their job, is to be reading through the documentation and make sure that if there are clinical indicators that suggest a diagnosis, that the doctor is making that diagnosis. And then the converse, if they make a diagnosis, do the clinical indicators support that diagnosis? Because you don't, obviously you don't want to commit fraud, abuse, or waste. And so you want to make sure that your documentation is supporting what you're thinking, what you're doing.
We're talking to Erica Remer. She's a physician and clinical documentation specialist. Her KevinMD article is titled Fixing the Broken System, Improving Clinical Documentation in Healthcare. Erica, I want to talk to you about the future and specifically AI and these generative AI tools like ChatGPT and Google Bard, and it's affected pretty much every field where the English language is being used, and is no exception when it comes to physicians and clinical documentation. So tell us, what do you see, and comment on that intersection between generative artificial intelligence and clinical notes going forward? Well, what are you seeing?
I do think that there may be a role for using some sort of artificial intelligence, especially in the context of the discharge summary. But, we all need to remember that garbage in, garbage out. So if you're doing bad documentation all along and you're copy and pasting and you're not putting in the detail that's needed to be able to draw the correct conclusions, then you're going to end up with garbage out. I do think that the bugs that they're finding with the artificial intelligence, where they're sort of just making stuff out of thin air, I think that they'll work those bugs out eventually. But I think that you got to be careful. And, we've been using computer-assisted coding and computer-assisted CDI for years now. And I always tell people to be really careful, because you can't just accept whatever the computer is telling you. The human being has got to read it over, because this is not busy work to me. This is taking care of real live patients. And if you don't pick up errors that the computer is inserting into taking care of that patient, you can end up, causing harm. And to me, that's the most important thing that we have to avoid. But I do think that if, one of the tools I tell people to do in the hospital for discharge summaries is to keep a running summary. So some of the electronic medical records have a place where people can keep, we used to call it the handoff tool. Yeah. And so what it would be, you could keep, have a one paragraph that was kind of telling the story longitudinally, quick summary, so that if something happened to a patient in the middle of the night, you could just read through that rather than having to read through pages and pages and pages and pages, obviously. And so what I would tell them is invest a few moments every day in keeping that updated. Mm-hmm. And then when you got to the end and you needed your narrative for your discharge summary, it was there, it existed. And so that's the kind of thing that I think that, the artificial intelligence might be able to cull those pieces and parts. But what you really need to do is make sure that it's telling the entire story. So what it thinks is important and what a clinician might think important might be two different things. So I think that everybody needs to realize that, you really don't want to be just an editor. You really do want to be an author. But I think that AI may have some role, but I think it should be a limited role because we're really trying to take care of patients.
And my final question, Erica, tell us some of your take-home messages that you want to leave with the KevinMD audience.
Okay. Well, I would like to mention that since there is nobody teaching this to anybody in the first place, I think that people should really understand that their clinical documentation integrity specialists are trying to help them tell the story. I actually created a set of modules called Dr. Remer's documentation modules, where I've sort of parsed out the important things. So I talk about general documentation. I talk about documentation in the context of quality and reimbursement, CDI, and then talking about supporting medical necessity and medical decision making. And so I have these modules they're packaged at one very low price. And I think that it's a really good tool for people to learn how to do good documentation and recognize that their CDISs are trying to help them tell the story. And so that's really my key. I would say you need to think about, like, every time you're taking care of a patient and documenting, you should spend a couple of moments thinking, okay, put your mentation back in your documentation. And then what you're really trying to do is tell the story, but you should always make sure that you're telling the truth.
And I'll have a link to your documentation modules in the show notes. Erica, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you, Kevin. Good to be with you. Take care.